Hi everyone, this is our third DARIA session for 2022. So today we've got Dr. Jeku Jacob, who's a registrar at St Vincent's Hospital, Sydney, presenting, and today is one of our first journal club sessions. So hopefully everybody received the paper that I sent out last week. I use the registrant information. So if you hadn't registered for this by then unfortunately you won't have received it. But please just message me and let me know, and I can send that through to you now if you wanted to have a look while we go along. I'd just like to start by acknowledging the traditional owners of the land on which I'm from today at St Vincent's Hospital, which is the Gadigal people of the Eora Nation. And I pay my respects to their elders past and present, and I extend that respect to any Aboriginal and Torres Strait Islander people who may be here today. Just a little bit of housekeeping before we start. So Dr. Jeku will be presenting, and then at the end, there'll be time for questions. If you have any questions that come up during the presentation, there's a Q&A function at the bottom. You can just pop your questions in there, and then we'll address those when we get to the question time at the end. And then at the end during question time as well, if you want to speak, just raise your hand and use the raise hand function, and then I can actually unmute you and you can speak to everybody, have a conversation if you want to. Any kind of administrative stuff, just pop something in the chat if you've got some kind of tech issue or you want me to send that paper through to you and you haven't got it. And so that use the chat function for that one. And then when you leave the webinar at the end, there'll be a survey to see how you all enjoyed the content today, if you found it interesting, if you found it useful. So please do fill that out at the end as well. All right, I will hand over now to Dr. Jeku to take us away. Thank you.
Thanks a million, guys. So, and thanks very much, Lucy. So I'm not sure if any of the consultants are here today, but I think Rob Page is an apology for now. He's currently in Gorman, and Christian Montier is away on leave. But I'll just get started. So this is a little bit of an agenda slide. So look, I've got about 38 slides here, and I tend to talk quite quickly. Please interrupt if you want me to stop, and we can talk about any specific points. There's more than enough time. But this is an article that was published in 2021 from the US about methamphetamine use. So, no secrets here. It is a positive trial, which is quite exciting, and we'll just we'll just basically be going through the journal and how they did things. So here we go. So again, the background. So the US has what I think is probably a similar methamphetamine use problem. So two large studies in 2017. So one was a survey of overdose deaths that was done in 2017, and methamphetamine was found to be in the 10 most found drugs relating to overdose. Now, I suspect that it's usually, I suspect that this is probably, those situations were probably polysubstance overdose, but nevertheless, it probably had some etiology there. And in another study from 2017, where data was collected from by survey of about 13,000 patients from 2011 to 2017, in the treatment-seeking opioid user population, there was an increase from methamphetamine use from about just under 20% to just over 33, so just over a third, which is pretty impressive. So, I mean, by comparison, the illicit drug reporting system study in 2019 showed that 76% of people who reported, 76% of users reported using ice in the last 6 months, and about a third of those reported that ice as being their primary drug of dependence. So overall, same but different. So very comparable. So there have been two drugs of interest in use in methamphetamine use disorder. So naltrexone, as we all know, is used in alcohol use disorder. But again, there have been at least 2 studies from what I've read showing some evidence in methamphetamine, which is interesting, and bupropion, which again we tend to use here, and which is second line in tobacco dependence, as well as an old antidepressant, has showed some evidence in methamphetamine use disorder. I don't think either of these studies or any of this evidence is randomized control trial. And again, a small pilot trial showed some, again, positive evidence for the combination of these 2. So again, quite interesting. So all of that led to this trial, which is called the additive study, or the ADAPT trial. So what they did was it took 2 years for them to do this, which is, and just shows how well designed I thought this was, but it was over 2 years. It was 8 different sites, and each trial, the trial overall, when it was started, it ran for about 12 weeks, but it did run for 12 weeks in different sessions at 8 different sites. It was a double-blinded randomized control trial, and it was done in a sequential parallel design, which I only learned about in when I was reading about this. What they were comparing was a combination of naltrexone depot, a 3-weekly depot, with daily bupropion. So that was the trial drug, or the treatment arm, and then the control arm was placebo. So they haven't mentioned this in the paper, but I presume that they gave sham shots and sham pills to the control arm. So I guess most of us understand what a randomized control trial is. You just have a control arm and you have a treatment arm, and then at the end of each session, at the end of the trial, then you look at the results and see what happened to which arm, and the hopes in those 2 arms is that they're evenly matched in all parameters and demographics and numbers. But apparently, if you do that for a lot of drugs in psychiatry, there's a very large placebo effect that's hard to overcome. And that doesn't necessarily mean that the effect is not there. It's just hard to see. And I suppose that means that usually that those trials and historically are very small. And so it's hard to overcome placebo and see whether it's significant or not. But what some clever people in the Mayo Clinic came up with was an alternative method of making randomized control trials. So you start off with a fairly large control group and a fairly small treatment group, and then halfway during the study, you take any non-responders in the control group, i.e., the ones who've gotten placebo, and you re-randomize them. And the end result is that you're enriching the final pool with people who have had the treatment. And I mean, it does make things complicated to look at it statistically, because what that'll mean is that, some people will have had treatment for the entire length of the study, whereas some people will have had treatment for only half of it. And so you have to play around with weighting and statistics and before you can make it all even. But the idea then is that you're overcoming placebo in a relatively small group, which is interesting. So, I mean, I put the slide in to just say, why would you do this? But I mean, I've just sort of answered the question. In general, you counteract the effects of placebo in a small sample size. I think the other potential here in our client group is that I guess we want more people to have a therapeutic benefit. And this might have been one of the aims. They, of course, didn't say that. So, like I said, if you're going to do a sequential parallel design study, you need to weigh, and you need to assign a weight and a fraction. And these are just I think these are things that we don't have to worry about in the scope of this meeting. Just it's just worth pointing out that some people didn't get all 12 weeks of therapy. Some people got 6 weeks of the treatment, and versus some people getting 12. And so there was obviously going to be a more positive effect in anybody who had 12 weeks of therapy, and that should not be compared to the people who got 6. It's apples and oranges. So you needed a way to factor that in, and they did that in the statistical analysis of the study. But then it does make you understand then, and it made me understand, you'd be aiming for numbers like you'd be aiming for 25% of the initial pool to be randomized to the treatment arm at the very outset. You'd only want a quarter. And so then in the 75% that was left, if you had non-responders, and of course you would, you'd roughly get 50-50 when you re-randomized. So you get overall 50% of the overall pool in your treatment arm and 50% in your placebo arm. So in this study, we took about, or they took about, we'll talk about the numbers, but they included adults, who were in the working population age, who needed to have moderate to severe methamphetamine use disorder as per the DSM-5. So anybody who had a concurrent substance use disorder was mostly excluded. Now, if we look at the data, if we look at the results table, there's definitely some people with concurrent use disorders. I don't know that they entirely excluded them, but I guess what they mean here was anybody who had a substance use disorder that stopped people from engaging with the study, much as we are in FOPIT. Now, anybody who had a medication interaction with bupropion and naltrexone was excluded. Anybody who needed opioids for an upcoming surgery or for a medical reason was excluded, which is completely reasonable. And anybody with a low seizure threshold. And then there were multiple other reasons that was decided case by case, but these were the broad ones. So again, we were randomizing, and randomization happened at week 1 and week 6. Patients were given 3 weekly injections at 1, 3, and 6 week marked by a trial clinician. And they were also supplied with blister plaques of extended release bupropion. They were also given a smartphone app that was designed to help them adhere. So, I mean, I'm presuming the app just reminded you when to take your medications. And they needed to present twice weekly to the center in order to provide a urine drug screen. A urine drug screen was tested with a point of care urine drug test, which tested for 10 drugs. And it also had a little safety, so it had an assay in the sample jar that measured the temperature, which is cool. So the sample was not accepted if it wasn't between 32 and 38 degrees Celsius. So it needed to be body temperature, i.e. your own body temperature, which is great. And so, and then apart from this, people met with a trial clinician weekly for counseling, adherence assistance, managing adverse reactions. And they also had scores done for cravings, for depression. So bupropion was started at low dose. It was titrated up in the study. If somebody had an adverse reaction or felt awful on it, it could be down-titrated to 300 milligrams. And over the last 4 days of the trial, it was tapered down. I couldn't find the craving scale that they used in the supplementary material, but it was a visual analog scale, and you rated it between 1 to 9. Or sorry, no, this is between 1 to 9, but there was a visual craving score that you rated, and that was done. I don't know what it looks like. I couldn't find it on Google either, but they did do another score called the PHQ-9, which is a depressive score, and it's rated between 1 to 9. And this is the score that you're seeing here. And they did this every week as well. And this was measured and as part of the secondary outcomes. So what were they looking for? So basically they were looking for anybody who could have 3 negative samples. Now, it didn't have to be negative for anything apart from methamphetamine, which is great. So they were looking specifically for 3 negative methamphetamine urine samples. And as I said before, each of those outcomes, each of those stats had to be weighted between the two arms. And, that's all sort of discussed in the statistics portion and the results portion. But the secondary outcomes were also fairly interesting. So they calculated a percentage overall of in each arm of how many negative samples there were, and they compared them between the two arms. As I said before, there was methamphetamine craving was assessed by a subjective score on a scale, depressive symptoms, and then finally there was also a treatment effectiveness score that was done again every week. And that was measured as part of the secondary outcomes. They also monitored patients, presumably with bloods and vitals, and for suicidality and for any adverse effects related to the medications. And there were a few that we'll talk about in the results. So what do they get? They got about 400 patients, so they got just about 400 patients. So they calculated that prior to starting, that they needed 400 patients. And they had a few assumptions that led to that number of 400, aiming for 90% power. Based on some previous data about the pilot trial of the combination therapy, they thought that they would see a 15% response in placebo arm, and they thought they thought they would see a 24% response in the treatment arm. So based on that, they thought they need about 400 patients. And all analysis was intention to treat. So anybody who dropped out of the study after stage 1 randomization was included in the study. They used a one-sided statistic to measure the confidence interval for the primary outcome, and they used the Doros method for secondary outcomes. Okay, so look, this is, I mean, I'm always so impressed whenever people do trials, and I can see why this took 2 years, but you can see at the top, they started off with a massive amount of people who were screened. And there's so much attrition prior to the start of this trial. I mean, our bit that we're really worried about is this, and this is really kind of what I was getting at in that drawing that I made with the 4 eggs, which I'll show again here. So we start off with 403 people, and then we're randomizing to about 109, which is your treatment arm, and 294, which is your placebo arm. And then at about 6 weeks, you decide, you do all the, you're checking urines, you're looking at results, and you're looking at the placebo arm for any patients who are not responding. Now there's 225 people at this stage who have not responded, and so they are re-randomized, and they've been re-randomized to about 114 in the treatment arm and 111 in the placebo arm. So overall, it ends up to be a little bit more. So overall, it ends up to be about 2/3 of the entire population. Sorry, about 50% of the entire population in the treatment arm, which is ideal. So so the demographics of the population is pretty much standard across the board. About more than 2/3 of all of the groups were white and male. About 1/3, again, across all groups, placebo or otherwise, were employed. They were mainly in their 40s. That was the median age. And on average had used for more than, I mean, nearly all of them had used more than 25 days in the 25 days before being consented to the trial. So this is just the slide from the trial, from the paper showing that. And I mean, if you have a look at this even briefly, you can see that the numbers are fairly stable across the treatment and placebo arms. and you can see one of the criticisms that they self-report, and the authors self-report to, is that there's a high predominance of men here, which, you know, I don't think was intentional at all. I think it's simply the way it all worked out. And the authors note, while this is a limitation, they did suggest this is probably reflective of the group that's being targeted. So adherence to the group is it was pretty good. Now, it's pretty obvious that it's way easier to adhere to a 3-weekly injection when someone's paying you money to show up for a trial, and then, you know, you're there, and then someone says, you know, shall we give you your injection? I suppose it's pretty easy to adhere to it, but it's not 100%, which is interesting. And then, of course, it's extremely hard to take a tablet, even if you're not a patient. I find it extremely hard. So all of these numbers make sense. What I found really interesting was that the adherence was slightly higher in the placebo group. And I don't know how to make sense of that at all, except to say, were people kind of getting tired of having no effect? I don't know. If you've got an idea, let me know. Sorry, it's a bit loud. But as expected, there was when we look at all of the outcomes, we are seeing a positive effect. So in stage 1, more than three times the number in control shown to have an effect. So 16.5% of the treatment arm had 3 negative methamphetamine samples, which is as opposed to 3.4%. And similarly, stage 2 had a similar sort of set of numbers. When we do the weighting and the averaging, the overall difference seems to be about 11.1%, which is, you know, as per their own stats, significant. In terms of the secondary outcomes that they looked at, so the number of people who had number of samples that were negative was definitely greater in the treatment arm. So 20.4% versus 12.3 in the control in stage 1. And similarly, again, 19.2 versus 13.4 in the control in stage 2. So slightly less in stage 2. And I think this is probably because of the greater amount of time that the people in stage 1 had overall. The weighted difference seems to be about 6.8%. Here are the weighted differences between the other scores that we had. So it's negative 9.7 for a weekly craving score. So and that's negative 9.7 only because people in the treatment arm, you know, had lower scores when it came to craving, which is what you want. Similarly, their depressive scores were ever so slightly lower, and they thought the treatment was effective overall. I guess, so what the authors have said is that they did not make any confidence intervals for the secondary outcomes. I wonder why. They cannot make any conclusions about what this means. So, and I don't know either. Here's a summary from them explaining everything that I've just said. Yeah. And I think it's more useful to look at this diagram, which is a visual illustration of what of the primary outcome. I mean, this is fairly impressive. And again, I think if you look at stage 1, there is you know, at least visually, it looks like there's a pretty good difference between placebo and treatment. So any bad things? Yeah. So there were 8 serious events in the treatment arm and 9 in placebo. So they're listed in the supplementary appendix. So I'm only listing out what happened in the treatment arm. So there was hypoglycemia, pneumonia, cellulitis, depression, acute cardiac failure, and gastroenteritis. But again, the p-values for all of these was really high. So the lowest was 0.27, which is again extremely high, and the highest was 1, which means that none of these were actually significantly associated with treatment. So I don't know that, in fact, they don't sound like they should be caused by either of those drugs. Most of the side effects were mild to moderate: nausea, vomiting, constipation, dry mouth, and abdominal pain. So what I think of the study, I thought it was really well designed. I mean, I won't lie, maybe I don't know enough about statistics to tease that out, but I thought it was well designed. There was a very clear primary outcome. It was representative of the methamphetamine using population. The sequential design is probably a double-edged sword, but uh, it was designed to overcome placebo, and I think it did that. And the intention to treat analysis makes the significance of this study very hard to refute, even though it does seem modest. So what are the cons? So the authors themselves admitted that females were not well represented. The other things that I thought about were whether the primary outcome should have been 2 negative methamphetamine urine samples, or it was just maybe 3 was just a bit too hard. If we were aiming for 2, would the benefit be more clear? I guess if I had the time and the money and the knowledge, I probably would have doubled the time in this study. I would have made it 3 months and see what would happen with this drug over 3 months in the treatment arm. I guess that's the burning question that I have. What would have happened if you had a longer study and if it was done as a traditional RCT where you just take 3 months and 3 months, placebo versus 3 months in treatment? So is this applicable to our population? I think we probably have a similar population here, methamphetamine use, in terms of age, ethnicity, and the use. It seems like this drug offers some modest benefit over a short period of time, and we need more data about the length of time, but it's certainly something that I could see myself using or trialing in a patient that doesn't have any contraindications, as long as it's an adjunct to rehab and psychotherapy. What should we think about? So naltrexone is not offered as a depot here. And bupropion here is, again, it's not offered as the modified release. It's only offered as a sustained release, as far as I'm aware. But that's about it. It was a cool trial. So the take-home message from me is what I think is that I think the combination has a modest and significant effect in MA use disorder, unless anyone can convince me otherwise. Questions, comments, concerns?
So we've got one question that came up during the presentation from Linda. So she's asked, how does dual buprenorphine, bupropion, and naltrexone effect compare to using them individually?
Oh, hi, Chris. Hi, Nadine.
Oops, sorry, was someone trying to ask a question?
They say why they use depot naltrexone. I can only surmise that that depot naltrexone seems to be fashionable because of a trial in homeless patients and alcohol dependence that was done in 2021, Chris. I can only surmise. I don't know.
We're just having some comments come into the chat.
Yep. Definitely not available here.
Ryan's also noted earlier in terms of addressing the PBS funding for bupropion, it's not PBS funded in Australia, is it?
Linda's asked, how does combination bup and naltrexone compared to using them individually? Well, we haven't compared them. I don't think the studies on each of the individual drugs were randomized control, unless Nadine knows different. Okay.
If anyone's got any more questions, just pop them in the question and answer box, or feel free to raise your hand and I can unmute you to speak.
Might just ask Nadine. Nadine, would you think that you would use this drug? Thanks, Krista.
Nadine, I'll unmute you if you want to talk.
Thanks. Thanks. Great job, Jeku. It is a very complex statistical design, that study, very original for our sector, really. So pretty exciting to see that. So you did a great job reporting it. I'm pretty keen
Nadine,
that we give it a go.
You.
Sorry? You can't hear me? Can you not hear me?
Oh, I can.
Oh, right.
Okay, all right, I'll keep going.
Well, it's just me.
It's just you, Jeku. You missed all my compliments.
Okay. I guess I'll find out from you later.
Yeah. I guess I'm pretty keen to try it here. I'm not sure, because we wouldn't be able to use the injectable, or it would be harder for us to use the injectable naltrexone that's not available here. We would have to rely on people taking the tablet of naltrexone and the tablet of bupropion. Bupropion probably has some mild perceptible subjective stimulant effects, so maybe people might like to take it. I'm pretty interested to see if people would be prepared to try it, and to see if they would see if we could trial it here to see if it could be helpful for people, because as you said, both those medications are available here in Australia, but for other indications. So they're already in the country, they've already got TGA approval, which is a good kind of head start for that. So I'd be pretty keen to give it a go. I guess I'd be keen to hear from you, Jeku, and for anyone else in the audience, if you think that would be something that our clients would be interested in giving a go, if you think we'd get people wanting to give up their time to be in a trial. Jeku can only listen and talk, not at the same time, not do both at the same time.
Can you hear us?
Yes, I've just unmuted Mary.
Oh, hi. So I think I would do it, particularly for people who wanted to go to rehab. So the clients who are coming off of methamphetamine in Gorman, I think it would be a great chance to enroll them then if they were keen, and then as long as they were going to rehab, for 3 to 6 months, I think they would probably benefit.
That's interesting, because most rehabs don't accept people on psychoactive medications.
Okay. Yep.
So they're probably
Yeah. Okay.
This is not being tested as a withdrawal medication. It's being tested as a kind of maintenance therapy, if you like, or ongoing longer term treatment.
Yeah.
But yeah, I think it'd be pretty. I think it'd be worth a go. Krista's saying, would be so disappointing if retention was lost without longer acting formulation and no effect with what we can access, or impressive if an effect was demonstrated with even without it. Yeah, so this is the big question about the longer acting naltrexone versus. I mean, I don't actually think it's going to make that much of a difference, because people have to take a daily medication anyway. So there's an adherence question anyway to the medication, and they'll be getting placebo. So we can do a combined medication in the placebo, so people don't know if it's the naltrexone or the bupropion, so they're just taking the medication or they're not. And it would be it's much easier to administer an oral preparation than an injectable preparation, and easier to administer something that's one thing, not the other. We know naltrexone on its own doesn't do anything, so it's quite complex to deliver a treatment that is a combo injection and tablet. So I'm actually pretty keen to try it as the oral formulation. As Chris said before, there is already a co-formulated diet pill that uses the same medications but at lower doses, and I just think this would be worth giving a go here.
Yep. Exciting.
But it won't have miraculous effects. We shouldn't expect miraculous effects. It'll have a small effect for some people, but it's still worth having more treatment options to offer our clients than we do already. Back to you, Jeku.
Oh, no, I'm good.
If anyone else has any more questions or comments, feel free to raise your hand. I can unmute you or pop them in the question and answer box.
Yeah, so Chris is raising a point. I think this is a really important point. Having a pharmacological treatment option can then also increase retention in the treatments that we know work, which are, you know, counselling and psychosocial support. So having something else to offer people can actually help people engage in a whole package of treatments that can lead to lasting change for people. So it'd be nice for us to have something. Our users love pills, says Chris. Not all. Not all, but there is, I mean, some people do like to have a pharmacotherapeutic option. I guess I'll just, if there's no more questions from people, I'll take the chance, given that Chris Tremonti is on leave, who usually chairs these sessions, to thank Jeku very much for running through that very complex statistical process for testing, you know, quite a complex intervention as well, and explaining that to us. So thank you, Jeku. It's not easy to do that, and you know, and allow us to think a little bit more on one of the few positive signals in the pharmacotherapy research for methamphetamine use disorder around the world. So hopefully this is the first of many promising signals. Any questions, shoot them through by email if you didn't get around to asking them today. And we were fortunate enough, you might still online, if you want to have a look at the NCCRED symposium from last year. Chris, I might have to get was it last year or the year before? We were fortunate enough to have a presenter that was involved in this. That was last year, Dr. Trivedi, who actually presented on this trial as well himself. So if you are interested in hearing more about this particular trial, you can go online to our NCCRED symposium from last year and have a look at Dr. Trivedi's presentation to explain a little bit more about the trial. And otherwise, look forward to hearing our speaker for next week. Chris has just popped in the little link for the symposium from last year, and look forward to catching up again next week, next Monday, 2:30, same place. And if you've got anyone that wanted to catch this presentation and missed it, they will be put up online as well.
Thanks, guys.
Thanks everyone for attending. And next week's session will be run by Dr. Hayden McRobbie, and he's going to be talking about a Cochrane review that he was involved with around using vaporized nicotine products for nicotine replacement therapy. So it should be a really great talk for everybody to attend. Thanks, everyone.
Thanks.
Thanks, guys. Thanks.
Bye.
Bye.